There are lobbyists that are on both sides of all these issues. As you mentioned, there are many on the pharmaceutical side and on the insurance industry side, and they're all going to be pushing their message. I will tell you, white bagging is probably one of my big priorities. It never made sense to me. I liken white bagging to someone determines that their car needs to be repaired. So they take it to the repair shop and they say, oh, by the way, you'll be getting the parts for the repair from my insurance company. They'll be dropping those off this afternoon so you can put those parts in there. And oh yes, and I'd like for you to warranty the work when you're done.
Hello, everyone, and welcome to the Rural Impact. I'm Michelle Rathman, and I do mean it when I say it, and I say it all the time. Thank you so much for joining us for another episode of the podcast dedicated to connecting the dots between policy and rural everything, or at least everything we can think of. First and foremost, if you're following us on YouTube, you can see that I am sitting in a very different space than normal, and that is because we have moved the studio and our set is not here yet. But nonetheless, we're back at it, and I'm so glad that you're here because today I am very proud to say that we have a very special Rural Impact on the Road episode in store for you. But first, just a little trivia to set the stage. Do you know what sets the state of Nebraska apart from 49 other states? All right. Well, of course, it's the Cornhusker State. We know football is all the rage there. And it's also the place where President Gerald Ford, entrepreneur, of course, Warren Buffett, and the inventor of Kool-Aid, Edwin Perkins, was born. All very interesting factoids. But the one thing that stands out above all else, to me at least, is that unlike the rest of the U.S., Nebraska's state legislature is unicameral, which means, if you didn't know, it is nonpartisan in that it does not officially recognize its members' political party affiliation or formal partisan leadership, structure. And it's an interesting way to legislate, to be sure. I do remember on a former podcast that I hosted, I actually interviewed an author who wrote a book all about it. Again, it's very interesting, especially as we apply it to the conversation we're going to have today. Because I was invited to join the Nebraska Rural Health Association and the Nebraska Hospital Association at their annual meeting in Kearney, a place I've been to often. And I do love Kearney, Nebraska, because it's an amazing place. 1 million sandhill cranes migrate to the Platte River Valley in order to fuel up before resuming their northward migration. I'm full of these facts this morning, but I digress. Now, during my time in Kearney, I did have the privilege to moderate a panel discussion with the leaders of the two organizations I just mentioned, Jed Hansen from the Nebraska Rural Health Association, and also Jeremy Nordquist from the Nebraska Hospital Association, as well as two state policymakers, Senator Mike Jacobson, really interesting guy, and Senator Teresa Ibach. And in just a few minutes, you're going to hear that discussion. But I want to note that while we're talking about Nebraska, you're going to quickly pick up on the fact that the conversation we're having is one that other states are having, and really at every rural health focused conference I've been to as of late. Now, also in this episode, I've included a few bits of candid conversations I had with conference goers, including a CEO whose hospital, their facility was literally hours away from closing. And you're going to hear how they saved that hospital when we have that conversation. And then I also had an outstanding conversation with an educator who believes that nurse engagement and health policy development is essential today and moving forward. You know, we hear a lot about staying in your lane, but at the end of the day, I think it's just amazing that we've got somebody out there that's ensuring that those who are pursuing a career in nursing understand the importance of health policy in their career. Lastly, before you sit back and tune out that noise and prepare your podcast frame of mind for this conversation, I do want to give a very special thanks to Jed and Jeremy for their hospitality and especially for their outstanding advocacy work on behalf of Nebraska's population, rural population, that is, which amounts to about 89% of the state. Another little fact that you may not have known. Okay, with all that said, my friends, I invite you to sit back and listen to this Rural Impact on the Road conversation. Are you ready? I sure am, so let's go.
With that, we'll bring on our esteemed panel here. We're going to be moderated by my good friend, Michelle Rathman. Michelle has been weaving in and out over the last couple of days, snagging many of you to be a part of her podcast. Michelle is a stalwart in championing rural healthcare causes, and we're so pleased to have you here. And then we have some real champions here. Senator Teresa Ibach, who was last year's Rural Health Advocate of the Year, and then Senator Jacobson, who is our 2024 Rural Advocate. So thank you all to the panel. Please welcome everyone to the panel.
Good morning. I had a lot of great interviews yesterday. I believe personally, I've been in rural healthcare for, May was my 35th year in business, and I have worked in 42 states. I lost count of how many hospitals. And I will say, Jeremy and Jed, the roadmap that you've put together, you could lift this and put this in any state because of the challenges that we're facing in every state imaginable. Maybe look a little bit different based on the topography, but at the end of the day, I think that you've done a brilliant job, and I hope to do justice by leading this really important conversation. I think for any of you who have been in rural health for any appreciable period of time, we're thinking to ourselves, when is it going to get better? And the work that you're doing is doing that. But as you said, Jed, we have a long way to go. So what I'd like to do is just begin with you, Jeremy. And the roadmap, again, is just an exceptional document that really serves as a blueprint for us to move forward. But what were the decisions behind what to include in the roadmap? That might seem pretty obvious, but let's talk about that for a moment.
Yeah, well, a lot of it from the NHA perspective, and obviously we did this in partnership with the Nebraska Rural Health Association, but a lot of it came from our association's strategic planning and member surveys speaking loud and clear that, finance and workforce coming out of COVID are number one and number two, and they are tied together, and we got to make progress on both sides of that equation. And then we got to address these other things that may not be as directly impactful on our bottom line as the rates that were paid, but are having a big impact, and that's post-acute placement and then the aggressive practices that we're seeing from commercial insurance. So when you look at this document, roadmap for rural healthcare, it aligns perfectly with what we're trying to do as an association overall.
It's kind of like the game whack-a-mole, Jed. I mean, I think we've had many conversations. We've been to D.C. together, and things keep popping up after you think you've kind of got some things under control. What are some of the things that have surprised you in your career and your position that have come up that you're like, really? How did this creep up on us and become an issue, a crisis almost?
Yeah, I think we have a couple of crises that we really are looking to address right now. I think rural aging is something that we really need to get a better handle on. We're going to have a continued aging population in our rural communities. Just generationally, we're going to have our baby boomers that are going to continue to age, and we're going to have to look for solutions there. The staffing, looking at kind of that whack-a-mole, looking at the LTC staffing legislation, and that's just something I don't know that anyone really knew where that one was coming from CMS, and so we're going to have to work very diligently moving forward. We've been lucky in our state where Senator Fisher and her team have been looking to lead in that area, but certainly one that I wouldn't have expected. And not only does that type of legislation affect our long-term care facilities, but it affects the staffing abilities for our hospitals and our clinics and everything in between. So certainly whack-a-mole there.
And it's challenging, isn't it? Because I was listening to Brock yesterday and talk about the word advocacy, which we're going to talk a lot about before the time this is over. These are issues that your community members, your patients, are not aware of. Does that surprise you? Do people say, I didn't know that was a challenge. I didn't know that was a problem. Does that surprise you both?
No, actually. When I get out and talk to folks, even in the healthcare field, I think sometimes our leadership knows it, our C-suites know it, but I think we've got to do a better job of communicating first even to our staff about what's happening with whether it's the finances, the workforce challenges, the post-acute challenges, the commercial insurance challenges. I think they get bits and pieces of it, but I take a PowerPoint that I have together on the state of Nebraska hospitals around Rotary groups and all sorts of different, community groups around the state. And every meeting, people are kind of shocked by what's happening when you paint the whole picture. And we just all got to be better about telling that story.
I think the roadmap should be a part of your clinic reading material sitting out there. Before we talk about policy, Jed, I want to talk to you a little bit, both of you, about the Rural Emergency Hospital. For those of you who have been following, this has been something that has been kind of a big question mark in many, many states. And of course, we know that Friend, I interviewed the CEO of Friend yesterday, if you're here, was the first to convert in this state. Let's just talk a little bit about some of I called it's a difference between you want a kick in the gut or a punch in the teeth, kind of mixing a metaphor there. What are some of the challenges that you see, as well as some of the opportunities for those who might be kind of on the fence as to whether or not this is truly a path to pursue?
Yeah, I think like most legislation, we don't expect it to be perfect. We go for the best that we can. And I think that the first iteration of REH was a good first effort, but we are going to have to look for reform. And I think really for those that are on the fence right now, looking at swing bed inclusion is going to be that vital piece. And then it's going to come down to really the direction that the federal government is wanting to look at with the REH as a payment model for our hospitals. If they're looking to expand that or like the program, then I think we may see 340B inclusion further down the road. But I mean, even things, we've got our great team from the Office of Rural Health and making sure that we can adjust our language for things like ship and flex inclusion so that our hospitals that are converting over to REH are able to maintain some of those key just kind of support pieces to them.
And you'll have kind of a long road ahead of you for any of you who are thinking about it in terms of just engaging your community stakeholders in the conversation. Jeremy, do you have any insight into, how do you even start that conversation? Because if we don't, most people don't even know that their hospital might be critical access and what that actually means. So let's talk about that.
I think it just gets back to the point I mentioned earlier, like being as open and transparent as we can throughout our entire community, because you gotta lay that groundwork. And on your podcast yesterday, you asked kind of how individuals could get involved or what they should be looking for. And I'm like, sometimes there are those warning signs that come up as hospitals start to close services that are needed in the community but just can't be sustained. So that's when the community needs to engage with the hospital, and that's when the hospital needs to be very active in telling the ongoing story of the challenges they're facing.
And I'll just add a little bit. One of the really, I guess, proud moments that I had as a rural advocate was helping a friend and the leadership team there go through this process. One, they need to be commended to they're really trailblazing in that space. But we went out as they were trying to decide if the REH model was appropriate for them. And we had a town hall, or their hospital team put together a town hall, and it was standing room only. And so it shows that there is that passion in our communities. Everyone wants to maintain rural health, and they understand the importance of maintaining rural health hospitals and clinics in their community, not just for the health of their family and their neighbors, but also for the economic health of their community.
It's an interesting story. As I remember, the hospital was just hours away from closing, and I have a saying, and you can quote me on this and use it if you like: the time to care about your community hospital is not when the doors are about to close, and the time to ask for help and support is not when you're desperate. And so to have those conversations, those courageous conversations early. We're taking a quick break from our panel discussion because we wanted to share an excerpt from my conversation with Mr. Jared Chaffin, CEO and CFO of Friend Community Healthcare System, who you just heard Jed mention as the first critical access hospital in the state of Nebraska to convert to the new Rural Emergency Hospital, known as REH. So here's a piece from that conversation. You recently converted from a critical access hospital to a rural emergency hospital. You are
Correct.
The first in the state of Nebraska.
Yes, ma'am.
So could you quickly just tell us what necessitated that change?
Mainly, it was all based on just financial stress of the hospital. Our swing bed program was very volatile from month to month. We never had a consistent head count, if you want to call it that, in our swing bed program. Inpatient was almost non-existent. So, we were really facing closure of our hospital. We were hours from closing back in July of 23. We had to go to our city council and ask for some funding for payroll. We are also the last city-owned hospital in the state of Nebraska. So with us facing those types of struggles, we just felt like REH was the best route for us.
Okay. And there's a lot of contemplation about that right now. So there's some, as with everything, there's some good and there's some bad. And I said it to somebody earlier, it's like you want to kick in the teeth or punch in the gut.
That's true.
And you have had to compromise some other programs as a result. So talk a little bit about what that has been like. You got an infusion, kind of a lifeline, if you will. But what were some of the sacrifices that you had to make as a result?
So becoming an REH, you are no longer allowed to do swing bed or inpatient. So we, are no longer allowed to admit patients from our ED into inpatient. So we have to transfer those patients out. And then we also can't admit swing bed patients from other facilities around us like we used to. For example, if some of our community members have surgery in, let's say, Lincoln or Omaha, and they need some post-acute care, in the past, as a CAH, we could take them on as a swing bed and they could be, back home in FNP, get their rehab and things that they might need. Well, we can't do that anymore. So our community members will have to go 20, 30 minutes down the road to be, that's as close as they're going to get to being back home in FNP for swing bed.
But on the flip side, you still are able to provide emergent care
Yes.
and other services. So you could still have CT scans and x-rays and blood draws and those services that are far more cumbersome to travel for.
Absolutely. Yeah. As a REH, we still have a 24/7 emergency room. And we also have a provider on site 24/7. Any minute of the day, our providers either in the hospital or they might be down the road at a restaurant, but they are always within 30 minutes. But we also have full lab and radiology services. We provide outpatient, whether it be wound care, or we also do endoscopies, so upper and lower endoscopies. We have a new 24/7 infusion clinic. So most infusion clinics in surrounding towns close down, 4, 5, 6 o'clock. Ours is open 24/7.
Yeah, that's fantastic. Now, last question I want to talk to you about is just really policy, because we know that, of course, swing bed you lost, and you also no longer get to take advantage of the ever so important 340B drug discount program as well. So, as we are out talking to policymakers, this is, as we heard this morning, this is an election year, and it's 24/7 really election years are. We always have to advocate for ourselves. What are some of the things that you want, the constituents you serve, the community that you serve? You are a government-owned facility. What are some of the things that we need to be telling our policymakers about bringing some things back? Now that REH has actually been implemented, we couldn't see what we didn't know.
It's true.
So what are some of the things that you think we should be telling our policymakers about wise policy that really makes sure that we are covering all the bases and making sure that we can stay financially viable and keep ourselves out of a vulnerable position as an REH?
Yeah. So I think one of the main things is we, as an REH, really need to have the ability to have inpatients. If we never get swing bed back, I can see that both ways, because going REH, we knew we would lose swing bed, but having the ability to have inpatients to where if we have someone come into our ED and we need to admit them, not having to transfer them to another facility 20, 30 minutes away, that's huge, not only for us, but more importantly for the patient.
All right, so now let's turn to policy, because we have a saying, all roads to quality of life are paved by policy. No matter which way you turn, the groceries that you have in your store, the healthcare that you receive, the transportation, broadband, there's a policy component to it. So we have two esteemed policymakers here today with us. So I'd like to start with that. Can you share some of your perspectives about the importance of being here, being involved, listening to your constituents, and just your roles in advancing policy that ensures that rural safety net, rural hospitals can get out of that terrible, vulnerable position and finally reach a place of thriving? So many are just surviving. How do we get to thriving? I'll start with you, Senator Ibach.
Thank you. Well, first of all, thank you very much for the invitation to join today. This group of folks is always so helpful in helping me absorb information, helping me know what the issues are. I'm always pleased to share the stage with Senator Jacobson because not only do we share a county, Perkins County, but we also share a real interest and a real love for rural Nebraska, including hospitals and healthcare, just because we both have experience with the challenges. We're both solutions-driven folks, and you all are a part of helping us be solutions-driven and finding the fixes that need to be fixed. Healthcare's changed so much over the years. When I was listening to Director Dannon talk about athletics, I think, wow, have we changed in the last several years on what the priorities there. Healthcare is much like that, and for us to adjust to the new formulas, the new demands on healthcare is really important. So thank you again for the invitation. I think that rural communities, rural healthcare, rural hospitals are the lifeblood, much like the grocery store is, as you mentioned before, much like our community centers are. They are the lifeblood of many of our rural communities. And I always use my mom and dad's experience in Callaway as kind of a footprint, because the reason they moved there was because they had a pharmacy, they had a hospital, and their doctor was there. Since that pattern has changed, but I know that the main reason they moved there was because of healthcare. And Callaway has been really, really good to my family and my parents' needs. And so much like that, I think we have to continue to encourage providers to move to rural communities, because without them, we do not have a local presence. The other factor that I usually look at are our rural emergency. I know most of ours are volunteer, and so it's very hard to wrap our brains around how do we encourage rural volunteer emergency services to continue, and that's very important. The other thing I would just point to, which we've already pointed to, is the $60 million that we injected, the legislature injected, into the UNC-UNMC partnership. Studies have shown that folks that train in rural Nebraska tend to stay there or return there eventually. And so I hope that that's a really good partnership. I really look forward to seeing the benefits and where that project takes us. The only other thing I would still mention that I've used a little bit over the last few weeks is the passage of LB 1313, which was Senator Dover's bill. What it does is allow agriculture organizations to establish their own membership-driven insurance programs. Many times, like I was 30 years ago when my husband and I got married, I went to town to work because they provided insurance. My job provided the insurance. What this bill will do will encourage folks that are extremely rural or outlying areas, if they cannot they don't have the capability of commuting to a smaller town or city for work to have that insurance coverage, it will allow them to do that. Or if they need to stay on the farm or ranch, this insurance program will allow them to have the same benefits that the traditional insurance programs provide, but at a much lower cost and at a need. So I would just point to those few things, and I know Senator Jacobson will build on it, but I think those are all really important factors and issues to think about.
Yeah, thank you. Very important. What say you? I know you have something to say about this.
Well, again, thank you too. I'm happy to be here, and I appreciate the invitation to serve on the panel as well. But I would just tell you that as I look at the legislature, there's always in anything you're doing a needed educational element, and usually lobbyists are the ones who have to provide that educational element. But I was very fortunate because I do serve on the board of Great Plains Health, and that really, if you could require every state senator to spend at least a year on their local hospital board, you would fix a lot of the problems that need to be fixed. Because I think most people cannot comprehend the challenges that we deal with. The fact that you treat everyone, the fact that you're going to have people who don't pay, many people who don't pay, that you're going to have Medicare, Medicaid who are going to pay less than your costs to operate, and then you're dealing with insurance, and insurance at every step of the way is trying to figure out a way to pay you less or allow you to get less. And we'll get into that later when we look at 304B, when we look at white bagging, just good examples of the challenges that are out there. How do we take more revenue sources away from the hospitals? So I've been fortunate. Ivan Mitchell is the CEO of Great Plains Health. Ivan and I talk on a very regular basis in addition to being on the board, and he's been a great resource for me. And so I would encourage all of you to continue to keep a close relationship with your local state senator, make them aware of the issues that we deal with in healthcare. When I look across the state, and I've always believed that when people locate in a particular town, there are things that they're looking for, okay? And healthcare is one of them. And as they get older, healthcare moves up their list of priorities. When you're young, you're invincible, it doesn't really matter. But as you get older, you start figuring out that healthcare is an important component. So besides housing, which is course critical, it's also, do I have affordable, accessible healthcare? And if I don't, that will impact my willingness to either move to that location or stay at that location. When I look at North Platte and you look at the statistics, we see a net inbound in migration of people that are older. And I would argue it's because of the hospital and it's because of the support facilities that are there, a senior living, assisted living, dementia, so on. Now, I'd also like to think it's because of the banking community, but I don't think that ranks that high.
Great banks out there. Great banks.
There you go. But so I think that's a big part of it as well. And so to keep that viability, and we can get into it, some other questions, but to keep that viability, we've got to continue to figure out ways, as we did step one with the Rural Emergency Hospital program, but now we got to figure out how do we bring those other amenities, 304B program, how do we bring in the other pieces, swing beds, et cetera, to be able to provide the revenue sources to be able to make that as viable as possible. It's going to be critical to have those, and the closer you have that healthcare facility to the person that needs the care, the better chance you have to save that life.
Senator Jacobson, you and I talked a little bit yesterday. In the rural roadmap, there are several, I think just really pressing, urgent. Let's find another adjective to describe them. So, of course, the telehealth. We don't want to put that toothpaste back in the tube. We want to be able to go ahead and continue to expand that. Makes sense. 340B, drug pricing, and of course, white bagging. That's another little whack-a-mole thing that came up. Can you talk a little bit about how there might be some legislative relief or pressure to help address some of these issues? Because when these lobby groups are so incredibly strong, we're out here just trying to, our voices can't be loud enough. So I know we need legislative relief. Talk about that for a moment.
Sure, no, I'd be happy to. Well, first of all, I think I'm going to take the same stance here that Director Dannon did, that hopefully what we say in here kind of stays in here, but...
You can trust us.
Yeah, it is true. Yeah, it is true. So I did serve on and continue to serve on the Banking, Commerce, and Insurance Committee. And the last 2 years I have been the vice chair of the committee. So the chair of the committee has decided not to run for her last term in the legislature. And so it is my intention to run for the chair of that committee this next year. Now, why is that important? Well, when you look at committee chairs, although every bill that comes to the legislature gets a hearing in the committee of jurisdiction, those bills don't necessarily need to be heard early. The chair decides when those bills get heard. If the bill gets heard late in the committee hearing time frame, after committee priority bills have already been designated, you've kind of effectively stopped that bill from moving forward. The other thing that the committee chair can do is decide whether or not they exec on a bill. Okay, what does that mean? That means if I don't like this bill, even though we've heard it, we're never going to take it to a vote in the committee. And if we don't take it to a vote in the committee, it never gets to the floor. The only way you can get it to the floor is to pull it to the floor, and most attempts to pull a bill out of committee to the floor fails. So committee chair has a lot of control over legislation. When the 304B bill was introduced, it got introduced the first 10 days of the session, and the bill didn't get heard till late. And we never exec'd on that bill, okay? Because it wasn't a priority for the chair. I will also tell you that when we looked at the discussions about white bagging, same thing. So it really kind of comes back to who are you listening to, who's influencing you the most as the chair of a committee to decide where the priorities are that you have. So it gets back again to first understanding the importance of these bills, understanding the importance that it has, and then using your role as a committee chair to schedule that bill early, schedule the vote early, get it to the floor, and move it forward. And so that's how some of those dynamics work. And so I think those are two bills that are very important. I'll also just mention on telehealth. I remember when we had the conversation about telehealth, everything was going along fine until we got to the point towards the end where there was an amendment added that we would require, if you're more than, I think first of all it was like 300 yards or something like that from the main campus, you'd have to have a special number, identifier number. Well, of course, that was for who? The insurance industry. Because they want to do what? They want to pay you less reimbursement for those satellite operations. So my argument as a banker has been, well, I don't understand this. If I am a bank and I open a branch at another location, how do my costs go down, okay? I mean, if I open this branch, am I not making my services more readily available to the community? Am I not just extending what I'm doing? And oh, by the way, if you're going to pay me less at the branch, what's my incentive to open it? None. I'm going to make everybody come to the main office if I'm going to get reimbursed correctly. It just made no sense at all. But yet there were those arguing that we got to do it differently. Why? Because they were talked to by the insurance lobby, told this is what we want, because we're going to drive down our costs by paying less in those remote locations. So that's a problem, and those are the things that get out in rural Nebraska, get into my district, where the 4 counties north of me, McPherson, Hooker, Logan, Thomas County, it is a long ways to anywhere. Okay, that's rural. And that's a real problem for those folks when it comes to health care. And we've got to be able to continue to provide. Without telehealth, how's this supposed to work? It doesn't.
It doesn't. Before we move on, I do want to throw kind of another subject on the table, because I think we would be remiss with this group to not talk about it, which is the cyber security threats that we're facing. As a part of this, we are looking at, from a federal level, we're looking at some new legislation, and I think we're probably coming at this a little bit later than we should have, because we are now the Change healthcare attack, and in Illinois, we've had a couple hospitals actually close as a result of cyber attacks, and they're never going to reopen. So is this a conversation that you're having now to talk about what kind of legislative relief, what kind of teeth we can put into addressing cyber threats? Because and Jed has heard me say this, a cyber attack for a rural hospital is the kiss of death.
Well, I'm not sure there's much legislation we can do for cyber. I think if somebody can tell me how we avoid all cyber attacks, you just well be the person that found the cure of the cancer, because it's a challenge. Everybody's faced with that. I think right now when it comes to cyber, we're just always constantly looking for what's the latest patch, what's the latest system we need to have out there. What concerns me more than anything on cyber is the cyber attack on United Health's program, and the fact that they have such a concentration of control over so many services. And if we ever learned what a monopoly means when it comes to problems, have a cyber attack at United Health and see what kind of an impact that has in hospitals across the country, rural and urban.
Yeah, Jed and Jeremy, you might have some ideas about some of the assistance that would be potentially helpful.
Yeah, well, certainly at the federal level, we've got to keep communicating to our elected officials, our delegation out there, as well as beyond just our delegation, of everything we're doing as an industry to protect ourselves. First, we need to be doing that, and then secondly, we need to communicate that, because Andy and I were in D.C. recently and sat in on a hearing in the House on the Change Healthcare cyber security attack, and it was a mixed and kind of across party lines of fingers being pointed at United, but a lot of fingers were also being pointed at hospitals as these big entities that should be able to protect themselves. And obviously, when we're talking about independent critical access hospitals, the resources are not the same as the HCAs and the Tenants of the world. So we've got to just be vocal about it. I think we should be advocating along with the American Hospital Association for more immunity. If we're doing things right and we're following what the federal government tells us to do to protect our data, and we do that, then why are we, when we're the victim in this situation, being held liable for this? So that's the message I think we need to push on. It's going to be a heavy lift because, like I said, there's policymakers trying to point fingers back at us as entities.
Yeah, I'm glad you brought up that point, Jeremy, because cybersecurity and cyber crimes are one of those interesting spaces where oftentimes we're still blaming the victim. And in many cases, the victim are our hospitals along with our patients. I agree. I think that we need to continue to push and look for legislation that's going to, if we're doing everything that we can, if we're being diligent within the four walls of our hospitals and we are attacked, that we shouldn't continue that punishment. And then, along with the change cyber attack, there were maybe some less than scrupulous actions that United started to take with some of our vulnerable hospitals and clinics, where they were trying to leverage that to expand their network. And so I think looking for a federal emergency fund that if an attack like this were to take place again, to make sure that payments can still flow to our hospitals should be relatively. I would think that could be a pretty palatable legislation that we could look at.
Low-hanging fruit.
Yes.
Yeah. That's good. All right. So Jeremy and Jed, what are, some collective policy priorities, because we are now in June, which might as well be 2025, because the clock just does not stop ticking. What should we be looking for from your offices in terms of your policy priorities? And then I'm going to ask the same thing of the both of you.
Yeah, just a big picture, I think looking at the upper payment limit and protection is going to be a real priority for us, making sure that we can continue to make sure that those dollars flow back to our hospitals over the coming years. EMS, significant issue, and we're going to have to look for creative solutions there. Had mentioned that we could look at scholarships, look at technical assistance, look at some telehealth integration in some of those spaces, mental health, making sure that we have those services available, making sure that we're continuing from a workforce standpoint through scholarship and through loan repayment, that we have the workforce that we need there, making sure that the payments align so that we can continue to offer those services. I think looking at aging in our rural communities and what we can do from everything from aging in place, looking at chronic care management, looking at remote patient monitoring services. What can we do to extend our workforce as much as possible to keep individuals in their home as long as possible in a safe space? I think collectively we would certainly look at those areas.
Yeah.
Jeremy,
I would just, and then outside of legislation, we got a lot of implementing of things. Still 227 and the workforce investments rolling out to continue to expand clinical nursing sites, and then the big kahuna for us that'll be 1087 and the work that we have ahead of that, and hopefully getting CMS approval no later than the end of the year and having that funding flow. Those will be critical areas of focus initially, and then when we get to next session, the priorities Jed mentioned, in addition to housing, workforce, and what I kind of view today is, and Jed, as we've talked about this as well, is kind of a kickoff to, a 5-month or so process of revising the roadmap to stronger rural health care. So when we get to the new legislature, which after this cycle of elections, 2/3 of our legislature will have 2 years or less experience. But we want to have a fresh, clean copy of a new rural roadmap. A lot of the priorities will probably be similar, but maybe some new policy ideas in there, as well as for our federal delegation.
Yeah, and I'd just like to go back to the partnership that we've been able to develop through this roadmap, being able to partner in with yourself and Andy and David, and you were able to show all of those wins that we had that were really rural-centric in their design and how we were going out there and doing that. And I think that it's a conversation. To your point, that we've done some good work, and we're looking for some good direction as we move forward into the next legislative cycle.
You know, and as you know, the time that you have served your state so well, we say there are no light subjects, but really it is about being enlightened, and there is a lot of learning curve. And so I wonder if you can talk about not just your priorities, but how do you work to help acclimate and bring your fellow legislators kind of up to speed, because we don't have a lot of time to make things happen in the short periods of time that you are together making decisions. So what are some of the priorities and ways that you help, as I said, support those who are coming in green and that you need them to get on board quickly?
Well, I would just say that this will be especially challenging this year because there are 15 senators that are leaving the body. So there's at least 15 new freshman senators coming in 2025. So our class, Senator Ibach and our class started out at 17. I think it grew a little bit after that. So there are very few, and when I talk about freshmen, sophomore, junior, seniors, I'm talking about bienniums. So Senator Ibach and I were here during the 108th session, so that biennium would be our freshman biennium. And so we'll be technically sophomores in the next biennium. The juniors and senior, those classes are very, very small. So our class is going to be tasked with a lot more leadership than maybe sophomore classes in the past have. And then you got this big freshman class coming in. So there will be a big learning curve. And there are lobbyists that are on both sides of all these issues. And as you mentioned, there are many on the pharmaceutical side and on the insurance industry side, and they're all going to be pushing their message. I will tell you, white bagging is probably one of my big priorities. It never made sense to me. I liken white bagging to someone determines that their car needs to be repaired. So they take it to the repair shop and they say, oh, by the way, you'll be getting the parts for the repair from my insurance company. They'll be dropping those off this afternoon so you can put those parts in there. And oh yes, and I'd like for you to warranty the work when you're done. That would be my comparison to white bagging. Okay, makes no sense at all. And if you ask the repair person, what would they be doing? That's great if you want to send in the parts. I'm not going to warranty the parts. And oh, by the way, I'm going to charge 1.5 times my labor rate in order to make up for the losses that I would have had on the margin on the parts. This makes no sense. And furthermore, when you start looking at some of the horror stories of infusion medications that get sent, dropped off by UPS outside in freezing weather, freezes, the product's no longer viable, it doesn't work, isn't any good. You've got that patient there that it's their infusion day, and so you use it out of your own stock and then don't get reimbursed because somehow it's your problem that the product that got mailed by the specialty pharmaceutical company got screwed up. That just is wrong. And I don't know why people can't see that. So a high priority for me this year will be eliminating this white bagging program altogether, and that will come with a lot of pushback on the other side, I will guarantee you.
So I think that's your invitation to get to know. Get your track shoes on because the lobbyists have them on. They're laced up and ready to go, and so must you, is to be able to invite them to come see your facilities, talk with your staff, understand the issues in terms that can be easily digested, perhaps?
For sure. And from my perspective, I think the challenges are great because with a large freshman class, there is a learning curve, as we both have experienced as well. But I think with that challenge comes opportunity because healthcare has changed so much in the last several years that we have an opportunity to educate a new class of freshmen on the importance of what's important to you. And as long as I know last night I had a great conversation with a couple candidates that will likely win, and they were asking me questions. And I think the more opportunities you have to help freshman senators, which you all will have freshman senators in your districts, to understand the importance of rural health, I think we'll all be ahead if we accept that and use it as an opportunity.
That's excellent. As I said, this is being recorded for the Rural Impact. We drop an episode every other Thursday, sometimes a little bit more, depending on how much content we have. And it has really just been a privilege to be here and be a part of this. I say Nebraska, I've worked in a lot of states. Nebraska is really a shining example of collaboration. So many states, they're Hospital Association and their rural health organization, they're Minnesota nice. I'm from Minnesota, so I can say that. But you truly are an example of what collaboration and the power of rural, where that is concerned. And I think you have some great opportunities. November, the third Thursday of November is National Rural Health Day. You may not know that. You may know that. And so use that as an opportunity to engage with your policymakers and your communities to amplify the work that needs to be done and the value, irreplaceable value that you bring to your community, because you can't get healthcare in a grocery store yet. So thank you very much.
Yeah.
Thank you to
Thank
all of
you.
you for your participation today.
Thank you.
Okay, you've just heard from a panel of policymakers and rural health experts talk about a wide variety of issues and priorities for the state of Nebraska. But before we close out this episode of the Rural Impact on the Road, we want you to hear from one more guest, and that guest is Melissa Florell. Now, Melissa has her Master of Science in Nursing with an emphasis on policy, management, and leadership from Yale. She is a PhD student, a native of rural Northeast Nebraska, and as you're going to hear, very passionate about rural health and nurse engagement and health policy development, a subject she teaches to undergraduate students. So here's what Melissa has to say about the importance of including policy as a part of educating individuals pursuing a career in nursing. All right, here's that conversation. And again, thanks for joining us on the Rural Impact. So we are talking about the importance of focusing on policy in the space of teaching, of educating our rural health workforce. Why is that important?
I approach policy as a conversation. And I think especially in rural areas, I have found that students have been raised that sometimes policy is a bad word, or it's a acrimonious
Certainly
word.
today.
Yes.
Yes.
And I want them to see it as a conversation about the places they live, they work, they want to raise their families. And I teach from that standpoint to start to break down the barriers to hopefully get to the middle of that polarity that we're seeing externally in policy, but especially with nurses. And I teach undergraduate nurses primarily, some additional pre-health professionals as well. I find that that's not why they've gone into their profession. They go into the profession because they want to help people. And without that understanding that policy affects what they do and who they care for, they're limited in their ability to make the impactful changes that they really want to make. And so that's how we start our undergraduate health policy courses, is talking about how do we have this conversation. And I think that once you pull that out, some of the really polarized news clips, and some of what I do is looking at our media and how our media portrays or exacerbates our hot button issues, I find it's easier for those students to then start to look at their colleagues and their counterparts and their instructors even, and say, this is what we're seeing. How do we prepare for this? How do we enter the workforce ready to make changes?
I cannot even imagine, because we've been having a lot of conversations about burnout, and a lot of people associate burnout strictly because of the COVID-19 pandemic. But it must be very challenging to square with the fact that, at first nursing and the profession was like, there are hometown heroes. And then we hear so much about workplace violence against clinical staff, nursing in particular, because they are so often the ones who are right there during patient care. What role do you see policy playing in ensuring that we are cultivating safe workplaces for them and that they feel empowered to speak to the challenges that they are facing?
One of the things that we talk about, and I will start by saying that workplace violence is one of the hardest topics that we cover, because I know that there is typically a 100% chance that every student that I send to the workforce will in some way, shape, or form experience workplace violence.
Rural is no exception.
Rural is no exception, with perhaps the exception being that there's fewer resources for those nurses that experience workplace violence to access, or it can be more challenging. But I really try, and I think that our generation of college students now, their superpower is using their voice.
Oh, wow.
But helping them channel that into a conversation that is proactive and helping them understand, okay, here's how you can affect policy change. Our elected officials are insurance salesmen, they are agriculture professionals, they are teachers. There are very few health professionals in our elected bodies, and it's our role to educate them about what you're seeing and how you, at the front line of healthcare, need to make change or how they can help you make change. And so those are some of the things that we model in undergraduate education and really help them to see policy as something that's closer to them and something that they can make a difference.
Not abstract.
Right. It's not this far
Right,
away
right.
abstract concept that they really can engage with their local leaders a lot of times, especially in our state. Our legislators are our neighbors. And so being brave enough to have a conversation or have your 30-second elevator speech in your pocket when you run into an elected official at a parade.
And it's so interesting because they're very hard pressed to find elected policymakers who doesn't have a nurse in their family,
Right.
especially if they're rural. Okay, the last question I have for you. Your students come in and they're taking this policy course. I'm sure you're awesome. I want to be a fly on the wall in your class. What changes from the time they start to the time they finish in terms of just their perception and their attitude about the role that policy plays in nursing?
So one of the most fun conversations I have ever had is with a recent graduate who left our program, came back as a grad assistant, and she walked into policy class and she said, I thought I was going to hate this class. I loved it and I use it every day. And that's very empowering as an educator. And I think that students learn what they didn't know. You don't know what you don't know until you get into that conversation, then you start to learn. So that is what I've had a lot of students tell me, and it's the reason I keep going.